Agree with me that cataract with uveitis is a very challenging case, peri-operative, not intraoperative. If you agree, raise your hand. It is a very difficult case for everyone. So, financial disclosure, unfortunately, no financial interest. Cataract is common complication of uveitis, 50% of those with anterior uveitis. Let's move. What are the indications of surgery? All of us know phacoantigenic uveitis, visually insignificant cataract, impaired fundus assessment, impaired fundus visualization. What are the poor prognosis? This is the risk factors to do good surgery, the patient not seeing, so he will not be happy. Macular edema, ischemia, atrophy, hole or scars, retinal ischemia, optic atrophy, glaucoma. When to do the surgery? No activity for at least 3 months. Okay? Behçet disease, inactivity for at least 6 months. Okay? You must weight the balance against amblyopia in case of pediatric children. What are the investigations? Do all investigations you know, but ultrasonic by microscopy is of utmost importance here too, especially in case of relative hypotony. If there is atrophied ciliary body, so there is high risk of hypotony. If cyclitic membranes are causing traction on the ciliary body, you must do vitrectomy, trimming of the ciliary membrane, and then silicone ion injection, otherwise atrophy will occur post-operative. So, counseling the patient. You must take long time. Counseling of the patient may take much more time than the operation itself because the risk of more complicated, more prolonged surgery, significant inflammation post-operative, delayed visual recovery, compliance with immunosuppressive, frequent follow-up visits, loss of accommodation, which IOL type, implant or not. Sometimes you can't implant. So perioperative optimization, careful control of perioperative inflammation, both pre and post-operative, is the critical key for success. Control of inflammation with least manipulation. Patient with no inflammatory activity should continue on their maintenance immunosuppressive agents. Patient on chronic oral steroids should prescribe a stress dose on the day of surgery. Pre-operative intravenous dose of steroids are recommended in cases where surgery is urgent with active inflammation in spite of heavy immunosuppression. What are the perioperative treatment? There is oral corticosteroids, topical, and intraoperative. Oral steroids is indicated more in severe cases of uveitis like uveitis, VKH, and Behçet, one-eyed patient if they lost their previous eye from uncontrolled inflammation. No recommended or consensus on one regimen, but usually 1 milligram per kilogram per day, single dose before 12 a.m. Then withdrawal tapering according to the response of the patient post-operative. Topical steroids, Mora et al. Says that intensive perioperative topical steroids was comparable to oral steroids in preventing post-operative uveitis, but recurrence rate was higher. So better to be oral steroids if there is no contraindication system. Topical steroids to reduce cystoid macular edema mainly. What are the special surgical considerations? Posterior synechia, poor pupillary dilation, epilenticular membranes, zonular weakness, and white cataract. All these are challenges. Intraoperative concentration, you must consider all these. Clear corneal incision, go away from the limbus, removal of pupillary membrane, wide enough pupil, wide enough rhexis, complete cortical cleanup. In the bag, IOL implantation is a must. If you implant IOL in case of uveitis anywhere away from the bag, it is complicated surgery. You must implant in the bag. Hydrophobic, acrylic in the bag. This is the only solution you have. Acrylic or PMA, avoid hydrophilic, okay? Peripheral iridectomy, you may need it in cases of severe inflammation and recurrent. How to remove epipupillary membrane? Either by peeling in this, or sometimes when you fail to peel, you can do membranotomy, like those in the posterior segment. Wide enough pupil, whatever the technique, you must have a wide pupil to have wide rhexis, okay? To avoid phimosis later on. Let's come to technique. This is a case of mild case of uveitis. As you see, there is epilenticular membranes, there is posterior synechias are present here. OVD, always I use soft shell technique, viscose, then heron. In all my cases, no financial interest. Try to dissect synechia, simple. Sometimes dissect it's simple. 360 degrees dissection. Trying to peel the membrane, as you see, try to peel it circumferentially, not radially to avoid this insertion of the iris, to induce iris dialysis. Okay? Pupil size is not sufficient. I am fan of Malugin ring to support the pupil, to have 6.25 millimeter pupil, delicate manipulation. Now, things are simple, going well. Do your large sized capsular excess, nearly 5.5 millimeter. At the edge of the Malugin, it is 6.25, so it is nearly 5.5. Good hydrodissection, sure. Then fecal emulsification. Remove, usually, this is the one fortunate thing, it is soft cataract. Usually in case of uveitis, it is soft cataract because patient complain of vision drop rapidly because of the complication of the uveitis. Dividing, use the technique as you like, divide and conquer, stop and chop, horizontal chop, what you like, do, no problem. But you must remove all lens matter because you don't need any post-operative inflammation. Take your time. Aggressive manipulations mean severe inflammation with complete complication. Cleaning cortex, polishing posterior capsule, as you will see. Very, very careful cleaning. I don't, the worst thing to have, the need to do YAG capsulotomy early. You will induce more inflammation. So, polishing the posterior capsule. I prefer to polish. Then implantation of the IOL in the bag. I routinely implant hydrophobic hydrophilic IOL. Then this insertion of the Malugin ring in the reverse manner, as you see. I need you to make focus on this membrane, which I failed to peel. Here, you must do membranotomy, multiple radial incision to avoid fibrosis and synechiae formation again. So you can do multiple radial incisions. I don't see clear. These multiple radial incision. In this condition, you solve the problem without compromising the iris itself to induce iris dialysis. You must remove all OVD well from anterior and posterior to the IOL. Pressurize it. I inject air here for documentation. The first day post-operative, subtenon injection of steroids. I routinely inject subtenon triamcinolone acetate. 1 day post-operative, as you see, the eye is quiet, no reaction, patient is going well, and continue with my uveitis fellow. This is more severe case with 360 synechiae, as you see here. Dissecting synechiae. Take your time. Don't hurry in cases of uveitis. Trying to peel, as you see, peeling the membrane. I'm peeling it circumferentially, not radially, please. After peeling the membrane, OVD, pupil not dilate, so I decided to implant Malugin ring. You will see in this case, surprisingly, very tough pupil. The pupil edge is fibrotic and tough even after peeling of the membrane. Trying to implant the Malugin, it's very difficult. It's repelling against me. No way, I'll push it with using the Osher manipulator. When you insert one eyelid, the other one jump away. It is very tough pupil. Here, I am catching Malugin ring inside, pupil can't dilate even with it. What I can do? I change the strategy to remove the Malugin ring, doing multiple sphincterotomies, as you see here. I rarely do it in case of uveitis to avoid the trauma of the iris. But here, no solution. Sometimes you're faced with a difficult, tough situations like this, multiple radial incision. And as you see, the size of the pupil after multiple incision will be sufficient to do routine cataract surgery, not those of uveitis, which I don't need any narrowing of the pupil intraoperative. I think most of you can do capsulorhexis and finish soft case like this of cataract if without uveitis through this size pupil. It's very nice. One, it is about 4 millimeter. But in this case, I can't rely on this situation because may catches the tip of the iris within the phaco-tip. The iris have a suicidal tendency as you need. I need to have a large capsulorhexis to avoid phimosis. I need to clean the cortex, so I insert a new malugal ring to support, as you see, the pupil. Now, you can do the surgery simply, doing the rhexis, OVD again, moving the lens, cleaning the cortex, polishing the posterior capsule to clean it to avoid early post-operative cataract. And if you can take a photo, please, for thank you. I am not looking for you. I'm doing my lecture. The removal of the malugal ring. Oh, you photographed me. Surprise. Then irrigation aspiration, cleaning all the OVD to avoid post-operative spikes, because spikes may occur from uveitis. Don't add OVD to more spikes. Subtenon, never forget to inject subtenon, triamcinolone 1 milli. Intraoperative steroids, you have intraoperative triamcinolone, as you see here. Injection of 4 milligram give good, effective, perioperative control of inflammation like systemic steroids. Intravitreal dexamethasone implant like Ozurdex, you can do it, especially those with case of pre-operative cystoid macular edema. You can implant it pre-operative. It helps in the reducing the inflammation post-operative. Subtenon steroids, it is very effective. It is as effective as 4 weeks of post-operative oral prednisolone acetate. It's very effective, very simple technique, very cheap. So, take-home message: delicate surgical maneuvers plus well-controlled perioperative, pre, intra, and post-operative inflammation will induce a happy, successful, excellent results in cataract with uveitis. All of you are invited for the Egyptian Ophthalmological Society in next May 7 to 9 in Cairo, Egypt. All of you are welcome, and thank you.
Thank you so much. We really got benefited by this talk. Thank you so much.